let's recap some important concepts in sexual arousal, comparing male to female sexual arousal. For male sexual arousal, know that parasympathetic activation is what mediates the erection. And when you have ejaculation, that's going to be mediated by the sympathetic nervous system. So emission as well as ejaculation is going to be sympathetically mediated. That's what's going to allow for peristaltic contractions of different structures to allow for the propulsion of gametes, the propulsion of sperm during copulation. And detumescence is going to be the term for the end of that whole entire phase, right? So detumescence will be the fancy term for the end of the sexual cycle for male. Now, for females, it's going to be kind of similar. There are going to be structures in the female anatomy that engorge, right, with blood. So engorgement of erectile tissues. It's also going to be parasympathetically mediated in females as well. There's also going to be glands that are important to provide lubrication. So you have cervical mucosal glands, vestibular glands. All those are going to help provide lubrication during intercourse. As well as the vaginal walls are going to be engorged with blood. And that's all going to be parasympathetically mediated. And then you're going to also have peristaltic contractions during orgasm. So very similar to males, just different structures. And then know that when the female orgasm, all this is going to be sympathetically mediated. I didn't include that on there, but it's going to be very similar to males as well. So the first part, parasympathetic. Second part is going to be sympathetic. So let's talk about conception and fertilization. So when a man ejaculates, that's going to involve about 3 to 4 milliliters of semen. Most of that is going to be just extraseminal type fluids that help to provide nutrients, right? So you had things like fructose in there, seminal plasmin that allows for the antimicrobial properties of semen. Only 10% of the ejaculate is actually going to be made up of sperm. And then when the sperm travel through the female reproductive system, only about 50 individual cells of sperm are going to actually make it to the area where fertilization can take place. So that's a huge war of attrition. You start off with almost 400 million sperm per ejaculate, and only a few of them actually make it to their final destination. So it's quite a trek. And then in order for conception to actually take place, the egg is going to have to be present, right? So remember that conception needs to take place anywhere between 12 to 24 hours of ovulation. After that, the time frame or the window for conception is basically going to be over. Some problems that sperm may encounter, going in the wrong direction, right? So that's one sad thing that might lead those sperm astray. They can actually get attacked by the female white blood cells, right? So that's one thing to keep in mind. Also, the pH levels within the vaginal mucosa is going to be really low, so it's going to be very acidic, which can, disturb the sperm. So let's watch a video on conception. This is actually a really cool video, and I will play the whole thing, even though it's 5 minutes long. Cool. So what's going on over here with conception and fertilization? So that's going to be taking place within the fallopian tube or the uterine tube. And then that's when you have the fusion of 23 gametes from dad, 23 chromosomes from dad, 23 chromosomes from mom. Once you have that fusion of those two gametes, now you have a quote-unquote zygote. So the zygote now is going to be diploid, right? Each of those gametes were haploid, just 23 or just one N, right? And then now it became a 2N or a 46 chromosome cell. Now, as you saw in the video, the sperm are going to have to be able to burst through the corona radiata. And in order for them to do so, remember the acrosome? The acrosome is going to be that little point at the very tip of the sperm's head. And the acrosome is going to contain a couple different enzymes that can help to digest and break down through the corona radiata. The two important ones are going to be hyaluronidase and then acrosin. Hyaluronidase, hyaline, that's going to be like a connective type tissue. There are other things that release hyaluronidase, including like Staph aureus. Hyaluronidase is going to be a really powerful substance that can break down all sorts of different tissues. And so sperm also contained that as well. So pretty cool. And then as soon as you have one sperm entering, that's when you have just everything chemically changes within the egg, and then now no other sperm are going to be allowed in. There are exceptions to this. Obviously, there's twins, right? So twins, that's when you have multiple sperm entering into the egg. So in other words, those sperm were able to enter in before that chemical change took place. So what's going on in this picture? Why did I include this in here? Huh? The IUD, yeah. So this is a pretty famous picture. I think it's hilarious. There's another one over here. So if you guys are on Instagram, I cannot stress enough, this page is so cool. Medical Talks. I keep on trying to convince my colleagues to follow this, but none of them are on Instagram. So I don't know. I think they're just a bunch of boomers. But I like Instagram personally, and I follow these guys. And there's some stuff on Medical Talks that are just so unnerving, but also some stuff that's really, really cool. So I included a little bit on birth control. I'm not going to get into the politics of birth control or the theological questions that birth control inevitably bring up, but this is something that you guys are going to be seeing in the future because lots of people are on birth control. And one thing to keep in mind is that birth control is not always effective. IUDs tend to be one of the most effective contraception methods, but clearly, judging by this image over here and the one that I showed you previously, they are not fail-proof. Sometimes pregnancy can still happen. So I included this chart here that shows all the different ways that some people might try to control their conception. So IUDs, those are going to be extremely effective. Condoms, pretty effective, but still, a couple slip through. So I just put that in there. I'm not going to make any statements or not trying to stir up controversy with birth control, but just know that it's very commonly used. So 25% of women are going to be using some form of contraception. The most common form of contraception are going to be your combined oral contraceptives. Right? So you have combined oral contraceptives that contain both estrogen and progesterone, but you also have contraceptives that are just progesterone only. So those are going to be called progesterone only pills. The estrogen and progesterone pills are going to be the most common of all of them. Now the way that this works is that estrogen is going to help with the menstrual cycle itself, so it's going to reduce bleeding. And then the progesterone is going to help prevent ovulation. Because remember, when ovulation is taking place, that's going to be during the follicular phase, right? So you have the follicular phase, development of the follicles with FSH being released. All of a sudden, you have that LH surge. Once the LH surge happens, then the egg pops out during ovulation. Progesterone is going to prevent any of that from taking place. And so it's going to allow for this negative feedback loop against the hypothalamus, so you don't have that LH spike happening. And then one of you all asked me last time how Plan B works. Plan B is going to be a drug called levonorgestrel, and that's going to also prevent ovulation as well as fertilization. Plan B tends to be a little bit of a controversial drug because it does have potential risk for actually aborting a baby. So this has been kind of up in question with regard to like the ethics about using Plan B as a contraceptive method, but it's widely used, so then I'm going to just leave it at that. So what's going on with after fertilization of the egg? Once you have the meeting of those two sets of chromosomes, right? So now you have 46 total, right? Now you have a diploid cell. Now that zygote is going to start to divide, right? And that's going to take various forms throughout the course of several days. You're going to have your first cleavage taking place as soon as you have that day zero, basically as soon as both of those gametes meet together. And then eventually you start getting a 4-cell blastomere. And then as that cell continues to divide and divide further, now it's going to turn into a morula. One way to think about it is it kind of looks like a mulberry. You got these different little sections on it. As you start getting further development of that morula, then it's going to become a blastocyst. A blastocyst, as the name implies, cyst means that it's going to be fluid-filled. So you're going to have a blastocele. The blastocele is going to be a bunch of fluid within the blastocyst. Around that is going to be a trophoblast. That's basically going to provide, protection and support for the growing cells that are going to be making up the inner cell mass over here. And that is what's going to eventually implant itself into the endometrial wall. So here's another image of what that looks like. You got the blastomere. Maybe this guy over here, 4 cells. As it divides further, it becomes the morula, and eventually it becomes the blastocyst. So the trophoblast that surrounds the blastocyst, that's basically going to provide structural support, separation from the outside world. And then you have that inner cell mass. That inner cell mass is what eventually turns into the baby. Okay, as the zygote continues on, becomes a fetus, right? That's going to be what eventually turns into the embryo, which turns into the fetus after 2 months. Okay. All right, so that's day 7. Okay, you got that. So here's a good summary of everything that's going on from day 0 over here, where the sperm meets the egg, all the way till you get to the point of implantation of the blastocyst into the endometrial wall. So it takes about 7 days for this whole process to take place. By the way, when it comes to IUDs, there's different types of IUDs. There's some IUDs that actually release certain chemicals. I think it's levonorgestrel is one of the things that they might release. But there's more natural IUDs, like copper IUDs. What copper IUDs do, not only do they basically kill sperm, right? Whenever they come in contact with sperm, the sperm effectively dies, except for the ones that are able to squeak past without being phased. And then the other thing that happens if you do get this formation of the blastocyst, the IUD also is going to help prevent the actual implantation into the uterine wall. So that's kind of how those birth control methods work. Ectopic pregnancy. Now, this is a huge concern. So some of the risk factors for ectopic pregnancy, women that have had surgeries, like abdominal surgeries, they might get adhesions. That's just fibrotic tissue that kind of surrounds the intestines, GI tract, and you can get adhesions that attach themselves to the reproductive organs as well. And so sometimes that might actually cause distortions within the fallopian tube, and because of that, you might get the embryo implanting into the fallopian tube, and that's a huge concern. One of the big things about ectopic pregnancies is that if it continues on, you can get a ruptured ectopic pregnancy, and that's a surgical emergency, and it can be fatal to the mom. So the way that you treat ectopic pregnancies, unfortunately, you have to terminate the pregnancy. That's basically the only way that you can do it. That's the safest way to protect the mom. Again, I'm not going to get into the politics of that. But here's another example of an ectopic pregnancy that I saw yesterday. This is super cool. Again, on Medical Talks. This lady, when they did the CT scan on her, she was 75 years old. She had this thing in her body for 35 years. And this baby right here, that's a calcified baby. So it's a lithopedion. Litho means stone. Pedion means child. That's a stone child. The baby, the embryo, was implanted outside of the uterus in the abdominal cavity. So it was in the peritoneum. Don't ask me how the hell it got any nutrients and how it survived to 7 months gestation. But this is a 7-month-old fetus, which is absolutely freaking incredible. The lady didn't even know she was pregnant. And she had this thing in her for 35 years. Eventually, she finally got the CT scan, and they saw this on CT, and I think it's freaking amazing. They should, in my opinion, take this and put it in a medical museum because I think it's super cool. There's only been 300 of these reported in medical history, so it's very, very, very rare. In other words, it's so rare that I'm definitely not going to test you on it. I just thought it was super cool, and it was kind of pertinent to what we're talking about today. So super cool. So that's a lithopedion. A lot of this other stuff that we're going to talk about is just FYI. I'm not going to test you on a lot of this stuff. So this is what's going on with implantation, where you have that blastocyst, the blastocele, etc. It's all going to be embedded within the endometrial lining. And then as you have the blastocyst and the trophoblast entering into the endometrial lining, then it's going to start getting integrated into the uterus, right? Then you're going to start getting development of all those blood vessels that help to provide nutrient and support for the developing fetus / embryo. And so this is all that's going on over here. So you have the blastocyst, trophoblast entering into the endometrium, and then you have all these blood vessels starting to form, and then you have the whole entire formation of, they call it gastrulation, and gastrulation is where you have all the different layers of cells now beginning to differentiate into what's going to eventually turn into like the neurological system, what's eventually going to turn into the integumentary system. So that's where you have differentiation of cells. So super cool stuff. One thing about gastrulation is you get this little primitive streak over here. That primitive streak basically now just kind of like subdivides the developing embryo into right and left components, and then you have all these different cells now starting to, differentiate to what's going to turn into future components of the developing fetus. So this is what it looks like at week 2. You have the chorion that's beginning to develop. Eventually, that's going to turn into placenta. And then you also have the yolk sac, which helps to provide nutrients for the developing embryo. And then moving on, you got the placenta. And the placenta is where you have the separation of the fetal blood from the mom's blood. Now, does blood from mom cross over into the developing fetus? It doesn't. There's going to be a separation between the two. But remember when we had fetal hemoglobin? So fetal hemoglobin has a really high affinity for oxygen. So that's how it's able to breathe, right? It's going to be taking that oxygen from mom because it has a really high binding affinity for that. And then the other thing that forms too is going to be that mucus plug, basically preventing anything from leaving the uterus, right, prematurely. Eventually, of course, like during birth, that's going to change. You're going to have dilation of the cervix during labor and delivery. So I'll show you some videos of that later on. As the embryo and the fetus are starting to develop, you're also going to have a lot of fluid that's going to begin to envelop the child. So that's going to be called the amniotic fluid, and it's all going to be filled within the amniotic sac. If you were to ever witness a cesarean section, when you cut open the uterus, you can see the amniotic sac, and if you perforate that, then all of a sudden all the amniotic fluid comes out during delivery. So it's very cool to watch. And then whenever you hear that term, the water broke, that's going to be the amniotic sac that ruptures. It doesn't always necessarily rupture before like cesarean section, for example. Sometimes you can still see it. If you follow medical talks, again, there's a video that shows what it looks like. It's very, very cool. Moving on. And then, so you have the amnion, that's going to be where you find amniotic fluid. You also have the chorion, and that's going to be where you have chorionic fluid. It's going to be all over here surrounding the baby. And then chorionic villi. And the chorionic villi is where you're going to see a lot of blood vessels. So it's going to be extremely vascularized. Right? So you're going to have a lot of gas exchange going from mom to the child. That's where also you have exchange of nutrients and things like that to provide nutrient support for the developing baby. All right, and then placenta. Now the placenta is kind of interesting. There's going to be a couple vessels. There's going to be 2 arteries, and there's also going to be 1 vein, and those are going to be associated with providing nutrients from mom to child. Now, when the child is ultimately delivered, when you cut the umbilical cord, that remnant of the umbilical cord is actually going to transform over time into the round ligament of the liver. So if you guys did any dissection, well, you guys don't work on the cadavers. Sometimes, depending on the cadavers that you work on, you can see the round ligament of the liver, and that's going to be the remnants of the umbilical vein. So super cool. So yeah, key thing to keep in mind here is that you're not going to have mixing of the blood with the baby. So if a mom has HIV, is the child going to get HIV? Yes or no? Could they get HIV? They could still get HIV, but it's going to be during labor and delivery. As the child is being delivered through the birth canal, that's when the child now can get exposed to HIV. But while the child is in utero, the child is not going to get HIV. As a matter of fact, there's certain drugs that you can use as prophylactic during labor and delivery. So if mom is indeed HIV positive, you can take different types of drugs. There's two major ones, and Zidovudine, I think, is one of them. So there's a prophylactic. You give it to mom as well as child. Unfortunately, even if you take a prophylactic drug, I think it's like 33% of those children are still going to be born HIV positive. So it prevents about like 2/3 of all the births from becoming, a vertical transmission of HIV from mom to child. But, it's better than nothing. But one thing about HIV patients, that if you have, HIV patients in the future, make sure that mom does not breastfeed the child, because HIV can actually be transmitted through breast milk. So that's one thing to keep in mind. So here's another image of all the different vessels. So you got your umbilical arteries, umbilical veins. You have the chorion, the amnion, etc. Now, in terms of circulation, so this is kind of interesting. So the child's not breathing, right? The child's hanging out in amniotic fluid. It's not going to be breathing. Once the child's getting close to being delivered, the child's going to start actually like practicing how to breathe, right, while it's in utero, but it's not like truly breathing. It's going to be getting all of its oxygenation from mom. So there's going to be a couple modifications within the child's circulatory system. So for instance, you have the foramen ovale. I think one of you guys said that when we were talking about cardiology, that they had a patent foramen ovale. The foramen ovale is going to be an opening between the right and left atria, and it's going to allow oxygenated blood to enter into the atria. Once the child is born, generally speaking, because of like increased pressure within the cardiovascular system, over time that foramen ovale closes. But sometimes you still get a patent foramen ovale. You also have a ductus arteriosus. And so the ductus arteriosus is going to be a connection from the pulmonary trunk to the aorta. And so you're going to be able to get oxygenated blood going from the pulmonary trunk into the aorta. Again, you can also get a patent ductus arteriosus. And if you were to listen to somebody's heart sounds and you hear that, it's like a machine-like murmur, that's going to be a pathognomonic finding that would indicate that the person still has a patent ductus arteriosus, which, generally speaking, you can correct through surgical intervention. All right, now we talked about HCG. So HCG was something that's going to be secreted by the developing embryo. And then HCG is going to allow for the maintenance of the corpus luteum. Because remember, with the corpus luteum, that's going to be secreting progesterone, progestation. You want to have that available so that it's going to help maintain the endometrial lining so that the child can continue to develop. And then the placenta is also going to be involved in secreting different hormones too. So you get the secretion of both estrogens and progesterone coming from the placenta. Now, a lot of this is going to be FYI, but this is what the developing embryo looks like. So this is going to be involving the neural plates. You have the neural crest. So these are all going to be the rudimentary elements of the developing fetus. So super cool. Eventually the neural plate turns into the brain, etc. And so here are some cool images of embryogenesis and the fetal development. So you can see all the different structures. So this is going to be at week 4. You can't really see any definitive structures yet, like hands. But by the time you get to week 8, look at that. You can see little feet. You can see little hands. You can actually see the fingers on them. So by week 8, that kid is already like becoming human. It's pretty apparent just by looking at them. Here's week 12. So week 12, that's going to be 3 months in. So this is still within the first trimester, right? This is about to get into the second trimester. So that is very much a developing child. You can already see all those features. 4 months, that is basically a baby. Now, the thing about children or babies once they're developing, now viability. Before, when I was in med school, viability was like anywhere between like 24 to 27 weeks if you were born premature. Nowadays, the technology is so advanced in healthcare that you can actually have a viable baby being born at 22 weeks gestation. I've spoken to a lot of people that work in NICUs, right, so neonatal intensive care. Sometimes they have kids that are 22 weeks old and they can still survive. They're going to have health issues, right? There's going to be some things that inevitably happen, but that child is still able to survive at 22 weeks. So that's pretty dang amazing and super cool. And so here's an image of conception all the way to delivery. That's a very, very interesting chart. Now, here's an interesting chart that talks about the things that can happen to the child while it's developing that could be potentially teratogenic. Okay, so anything that's a teratogen is going to be something that can harm a developing fetus. There's lots of medications that are teratogens. Alcohol is a teratogen. Drugs can be teratogens. So lots of different things, especially within the 3 to 8 week window. That's like the height of vulnerability of the child. That's when the child is extremely vulnerable, especially to alcohol. What does alcohol cause to a developing fetus? Do you guys know the term for that? Fetal alcohol syndrome, exactly. So fetal alcohol syndrome is especially concerning within that 8 week window. Do a lot of women know that they're pregnant until 8 weeks? A lot of women don't know that they're pregnant. Does that mean that they're probably still drinking and boozing it up, maybe partying, especially if they're young? Yeah, so a lot of folks don't know that they're pregnant, and they still continue to drink alcohol. And so that's going to be one thing to keep in mind for those who might be seeking or looking to have a child at some point. So make sure to keep that in mind. So these are all the abnormalities that can happen. You can have abnormalities of the heart, limbs, etc., neurological abnormalities. So all the red, those are all the vulnerable points, right? All the red is going to be like the danger zone. So you want to keep all of that in mind. I'm not testing on any of this, but just keep this as a reference for yourself, especially those of you who are going into obstetrics. This is going to be an important thing to keep in mind. So, as I mentioned, I'm not going to be, I want to play those videos to you, but I want to make sure we have enough time. Let's just go for it. These videos are really cool. If we don't have time to do the quizzes, I already did the quizzes for you guys, so I should have had your attendance information on there, or participation points, rather. If I don't get to the end for the quizzes, do those on your own time. So I put those in there just so you can focus on the important aspects of this lecture so that you're ready for the final exam on Thursday. So let's watch some videos. All right. Super cool. So here's an image from your textbook of what it looks like when there's a baby inside the abdomen. So you can see all the GI and all the contents within the abdomen have to kind of get squished up a little bit so that they can accommodate the developing child. During birth, there's a couple ways. If you have like a really stubborn child that doesn't want to get out of there, you can use vacuum-assisted birth. You can also use forceps. These things do carry risk. For the vacuum-assisted birth, not as much, but I've seen some pretty horrifying damage done by forceps-assisted birth. So they all carry risk. Now, in terms of gestation, so it's going to be about like 40 weeks, 42 weeks-ish. You can get premature rupture of those membranes in around 37 weeks or so. And if it's preterm, that's going to be before 37 weeks. And as I mentioned earlier, viability has definitely improved. So you can have a viable child being born at as little as 22 weeks. If you guys remember when we talked about oxytocin, oxytocin's that love hormone. Oxytocin's also going to be heavily implicated in allowing for all those contractions to take place to allow the baby to be born. And then the amniotic fluid will eventually rupture so that you get the water breaking, and then you have muscles relaxation, right? You have the cervix having to relax and dilate to allow the baby to be finally born. And by the way, if you see vacuum-assisted birth, it kind of distorts the head. It goes back to normal after a while, but they kind of look like cone heads, if you've seen that movie before. Or like this, a little bit more dramatic. But this is kind of a normal presentation for a baby that's born. And then this is going to be the vertex of the head. And the vertex of the head is what ideally is supposed to be coming out first. Breached position, that's going to be a really bad situation. That's if a baby's trying to be born feet first. You don't want that to happen. Generally speaking, those babies are going to be delivered through cesarean section. You're not going to want to do normal labor and delivery through the birth canal. And then after the baby is born, you can't let the placenta stay behind. So you deliver the placenta, And what you have to do when you deliver a placenta, you have to make sure you look at it. There's nothing missing. Because if there's any retained products of conception within the mom, that can become infectious, right? So the mom can develop sepsis as a consequence of that. So that's a really dangerous situation. What's up? Placenta previa. That is where you had the placenta. If I remember correctly, that's where it's covering the cervical os. Let me look it up real quick because it's been a while since I looked at that. I don't want to give you any false information here. Because you can have the placenta in different areas where it's not necessarily supposed to be. Yeah, so it's going to be placenta previa means the placenta is at the cervical os. So in other words, it's basically blocking the ability for the baby to be delivered. So if you had placenta previa, that child would have to be born through cesarean section. Great question. Glad I remembered that, so I didn't tell you a stupid answer. Let's see what else you need to know here. Cool. Now, remember I mentioned that sometimes you have more than one more than one sperm being involved. So if you have fraternal twins, that's going to be involving more than one sperm. But if you have identical twins, that's going to be monozygotic twins. That's going to be a little bit different. And as I mentioned over here, no one really knows why this happens. Okay, so it's kind of an interesting phenomenon that's not well understood. And it's going to be very random, and it does not run in families as opposed to fraternal twins, which can run in families. Now, one thing to keep in mind about identical twins, know this term, monozygotic. Okay, that's going to be the term for a identical twin. Now, if it's a fraternal twin, that's going to be dizygotic. Okay, dizygotic, they're not identical, so they're going to look a lot alike, right? They're going to have genetics from mom and dad, so obviously they're going to have similarities in terms of their phenotype, but it could be sisters, they could be brothers, it could be a brother and sister. They're not going to be genetically identical, versus with a monozygotic twin, they are basically identical. I had friends, there was these two sisters I knew when I was still in undergrad, and they were identical twins, and it was freaky because one of them would start speaking and the other one would finish their sentence. Like they would have the same thought process. It was really incredible to see it. Has anybody in here ever had any friends that were identical twins? Yeah. Did they do something like similar? Would they like finish each other's sentences? Would one of them try to look different so that they can be distinguished from each other? Yeah. So these ones, they were redheads. One would dye her hair blonde so that she would be distinguished from her sister. But they looked exactly the same. So it's pretty interesting phenomenon. One thing over here that's another recent controversy that's been kind of cropping up in the medical community is IVF. So that's in vitro fertilization. IVF, you get implantation or conception of multiple different eggs, right? So you get development of multiple different embryos. Generally speaking, they'll choose a few of those to implant into the uterus. The rest, they cryogenically freeze them, so they're kind of like conceived and like left there in perpetuity. So that's why it's kind of controversial nowadays. But with IVF, you get an increased rate of dizygotic twins. And it's kind of hard to tell if they're going to be dizygotic or monozygotic just by looking at a ultrasound. So it's really impossible to tell. You'd have to do genetic testings or just wait until the child actually gets born so you can be able to determine what they are. And then let's finish up with conjoined twins. So conjoined twins is where you have two individuals being conjoined in different parts of the body. It could be conjoined at the head, it could be conjoined at the shoulders, the hips. Lots of different types of conjoined twins. The kind of the lay term, bless you, the lay term for that is going to be Siamese twins. That's probably what you heard more commonly used, but the other term is going to be conjoined. Sometimes, depending on what organs are involved, you can actually have separation of the conjoined twins. However, if it's involving the brain, right, any sort of neurological tissues, then you cannot separate those individuals. They're going to have to remain conjoined effectively for the rest of their lives. If they have any other vital organs that they might share with one another, you cannot separate them. So if you separate them, that could either result in death of at least one of them, or even, if not, both of them during the surgical process. So Let's do another quizzes question before we finish up. I didn't know we would have time, but I'm glad we did. You're gonna have to log in again, unfortunately. Bless you. Yes. With identical, yeah, with the fraternal twins. Oh, sorry, with the monozygotic. Yeah, one egg, one sperm. Dizygotic is going to be involving two different sperm in one egg. All right, so I'm going to go ahead and hit start just for the interest of time here. All right, good. So very similar to the male reproductive system. It's going to be parasympathetic, right? So that's where you have the engorgement of those erectile tissues. What's going on here? Why did it say that? Why did it finish? Weird. Must have been some sort of glitch. Anyways, next. All right, good. So the zygote, that's going to be the fusion of those two embryos. And by the way, with the difference between monozygotic and dizygotic, with monozygotic, it's going to be one egg, two sperm. In dizygotic, it's going to be two eggs, two sperm. Okay, so the two eggs and two sperm are going to develop simultaneously for dizygotic. All right, awesome. Yeah, the acrosome, that's going to be at the very, very tip of the head, right? So that's going to have those enzymes like hyaluronidase, and that's going to help to break through the corona radiata so it can gain entry into the egg. right, good. Yeah, so false. You're not going to get a mixture of mom's blood with the child's blood while the child is developing in utero. All right, two more. All right, good. Monozygotic, that's identical, okay? Dizygotic, what's that called? Fraternal twins, good. Good, awesome, good job, guys. So, yep, fraternal twins are going to be the most common of all of those. So, for Thursday, make sure you watch that review video that I put up, and good luck with everything. I'll see you guys on Thursday, and have a wonderful rest of your day.